Good morning and welcome to the meeting of the Essex Health and Wellbeing Board. I will go around the room in a minute. Let me ask Will Hooper to give the hygiene announcements. Those who are curious about my tie, it is no coincidence. Those who are worried about Will's fungus, it is due to his starring in Colchester Theatre in a wonderful no-card production. But you are going to give, in dutifully no-card terms, please, Will, the due announcements.
Yes, so this is a public meeting and we are broadcasting the meeting via YouTube. Recording will be available afterwards on the Council's YouTube channel. I know you're all avid viewers. Just to remind you that the speakers in the ceiling are extremely sensitive, will pick up any background noise, so do try to keep it to a minimum. There is no planned fire drill this morning. If the alarm sounds, follow the officers out of the building in a calm manner and gather in the cathedral grounds across the road. Now, in terms of seating, the aim is always to try and seat the formal board members in this front row here. If anyone who's sitting along the back wishes to speak and there's not a space for them at the front here for them to do so, please do remember to speak up, because it can be otherwise a bit hard to pick up what you're saying. And then there are some, I think if I pass over to you for the remainder, so Chloe.
But if we can just start, we will go round the apologies in a second. I just want to note we have one new person at the table, I think, as far as I know, which is Garth Randar on behalf of Hearts and West. For about 2 weeks, I was aware of him being chairman of Hearts and West on an interim basis. He's now vice chairman, such as the National Health Service. And you will have noticed, ladies and gentlemen, we have one visitor from beyond the grave. Last week, at our last meeting, I gave a glowing epitaph as Michael Thorne left us as he went into retirement. For reasons best known to himself, he's back. And I just want to say, Mike, if and when you ever leave this board again, I'm not going through all that ring. Quite painful enough to do it once. So apologies, please.
Thank you, Chairman. We have apologies from Councillor Brian Butland, Councillor Lee Scott, Councillor Maxine Zazar, Dr. Frida Batty, Sam Glover, Sarah Troop, Tom Lafferty, Tom Walker, Tony Coles and Nicole Wood.
Thank you very much. And we'll just go around the room for the benefits as we all know who each other is. John Spence, Cabinet Member, Children's Services, Adult Social Care, Public Health and Integration. Will
Hooper, Cabinet Office Advisor to John Spence.
Chloe O'Malley, Democratic Services.
Operation Lead for Mid-Essex Recovery College.
Hannah Lincoln, Executive Director for Children, Families Education, Essex County Council.
Peter Davey, good morning. I'm Vice Chair of both the Essex Association of Local Councils and also the National Association of Local Councils.
Morning everyone, Gert Trandauer, Deputy Chair at Hertfordshire and West Essex, ICB.
Thank you.
Morning, Mike Thorne, Chair of Mid and South Essex ICB.
Morning, James Horden, I'm the Chief of Staff for Mid and South Essex ICB.
Morning, Councillor Casrisby, District Councillor, Cabinet Member for Health and Wellbeing at Epping Forest, but GP Partner for West Essex as well.
Thank you.
Good morning, everybody. Dr. Anna Davey. I'm a GP in Coggeshall and I'm the Primary Care Board Member for the Mid and South Essex Integrated Care Board.
And Anna, I think I've heard you get the attendance prize for the last 4 years. So well done.
Thank you.
You and Peter Davey, it was a close run thing. Yeah.
Good morning, everyone. Wahid Khan, Chief Superintendent, Essex Police.
Good morning, Gina Placey, Partnerships Portfolio Holder for Tendring District Council and the North East Essex Alliance Political Representative.
Good morning, everybody. Jane Gardner, Deputy Police, Fire and Crime Commissioner.
Good morning, John. The first goal was brilliant. The final goal was the most audacious. Nick Presmek, Executive Director, Adult Social Care.
My senior officers very kindly agreed to join me in supporting Scotland last night, so thank you for that, Nick. You may later try to explain to people why you are supporting South Africa against Ireland. But Helen?
Ian Davidson, Chief Executive, Tendring District Council and Vice Chairman of the Board.
Sarah Muckle, Director of Wellbeing, Public Health and Communities. To go back this way.
Okay.
Democratic Services.
Sorry?
Gemma Bint, Democratic Services.
Emma Hunter, Democratic Services.
Lizzie Kingsford, Head of Services in North East Essex for the Essex Child and Family Wellbeing Service.
Rosie McKern, Acting Business Unit Head for the Essex Child and Family Wellbeing Services, HCRG.
Mark Carbaron, Policy Officer for the Police Fire and Crime Commissioner.
Okay.
Morning, John. Chris Martin, Commission Director, Children's Services, Essex County Council.
Ali Armstrong from North East Essex Alliance, and I'm very proud to be celebrating Scotland's victory as well.
You can build up a theme.
Ian Tompkins, representing Herts and West Essex NHS, Harlow District Council and Essex County Council, and I used to work with Steve Clark, so I've sent him more.
Thank you.
Hi everybody, Amy Jackson, Deputy Director for the West Essex Health and Care Partnership, deputising for Tony Coles.
Dr. David Tideswell, I'm a GP in Dunmow and I'm clinical lead for...
I'm sorry, I really didn't hear that.
Say again, David.
Sorry, Dr. David Tideswell, GP and clinical lead for Care Close to Home West Essex.
Thank you very much.
Will Herbert, Head of Integration and Partnerships at ECC.
Emily Satchern, Senior Wellbeing Public Health Officer.
Catherine Thompson, Consultant in Public Health at Essex County Council.
Jane Fleming, Deputy Cabinet Member for Adult Social Care.
Chris Carpenter, Senior Equalities and Partnerships Advisor.
Shami Girotta, Head of Partnerships and Equalities at the County Council.
Good morning, Kirsty Webwood, Director of Operations from Brimfield Hospital.
Andrew Lowing, Equalities and Partnerships Team. Nathan Rowland, Equalities and Partnerships Team.
And good morning, everybody. Will Pope, I'm Chair of Suffolk and North East Essex ICB, and apologies for not sitting at the table, but I've got to go out at for a all-staff meeting, John, at 10:30, so I thought I'd sit near the door. Also, great result last night. I might get a bit of trouble at home because my wife is Danish, so yet to be resolved.
And your typical thoughtfulness and think about where you sit, so thanks.
Thank you.
That's it?
We've got Deborah online, Deborah Stewart.
So online joining us.
Hi, good morning, everybody. Thank you, John. Can you hear me?
Yes, very lively.
Oh, great. Thank you. So Deborah Stewart Angus, pleased to be here, and the independent chair of the Essex Safeguarding Adults Board. Thank you.
And with a name like Stuart Angus, two possible references to your heritage. Apologies, please. Who's got the apologies? Oh no, we've done that. Sorry. Right, we come to the action log. The action log has been, start. Minutes. The minutes of the last meeting have been circulated. Did anybody have any issues with the minutes? And if not, I shall take them to be agreed. The action log has been circulated. I think there was one action we needed to pick up, Will.
They were all complete. There was one outstanding, and I don't know if you've had any involvement with this. It's about Laura Taylor Green liaising with Adrian Goggins to coordinate distribution of material via Ian. I don't know if there's any update on that at all.
I'll pick it up with them to make sure it's done. I'll pick it up after this.
Okay, can we?
Yeah, absolutely.
the non-executive directorship arrangements, and we know we're going to beef up our children and families arm, because we know that's probably a slightly underdeveloped muscle in the ICB. So we're very aware of that. Nick, your challenge about how we define integration is a really, really great one. I think for the ICB, the definition that we need to land on, or the methodology we need to land on, is what is the difference between public and patient, because we do tend to only arrive at people when they formally enter our service. We know that it's something that local government does a lot better than us. That there will be a common bucket of services that everyone should be able to expect from the neighbourhood health hub. So I think that the right first step to nailing that definition is nailing the bucket of services that should be common across the entire population, that 80% issue. And then the next tier is defining the 20% issue that should be variable based on the neighbourhood it's in. So if we can arrive at that bucket, I think that's the type of conversation that we need to bring back to you quite quickly. Ian's comment regarding police, etc., is why we're doing this pilot in Chelmsford, because we know that anecdotally we think we've already arrived at a figure of frail patients who end up at one of our acute services have probably seen the police or fire services up to 4 times because of either falls in the home or because of being victims of scams. At the moment, I think it's probably fair to say we just probably don't know enough about each other and enough about our services with each other. So that pilot is very much looking at how we can get that common view and then just mainstreaming it across the entire ICB, and not just having it as an isolated pilot. The NHS loves a pilot. They love a pilot so much we've got some that have been running for 15 years. So that work is well underway. And then finally, Chair, I'm glad you're filled with optimism. I think we all are. Mike tells me we're full of optimism, so it's definitely the case. So I'll just reiterate again that the big ask from us as the ICB coming out of this is have those conversations internally, try to help us map who is standing up what neighbourhood structure, who is preparing to stand up something to manage localism, to manage the community and voluntary sector as we go forward, because we have got designs on these convener models to manage that community relationship and charitable sector relationship. We have got the designs of these health hubs that we've got to get done in the next 49 days. But we know that other people have their own priorities and we want to interlock, and the family hubs is a great example of how we want to interlock. We've got this period to get it right. The worst thing imaginable would be we go live with something in January and we find out that we have pancaked a lot of good work that's already being done because we've imposed a structure over the top that doesn't make use of the assets that are already on the ground.
Thanks. Thank you, Joe. The wonderful thing about being surrounded with optimists is if our optimist fades, we can all blame you. So we are running a bit late, but just I think it would be wrong for me not just to mention that the government has opened this morning the consultation on local government reorganisation in Essex. This is the first consultation, and they've decided to take all the 4 models proposed to government out in this first instance. This will go on until very early in the new year. The government will then go away and will come back, we expect, early in February to tell us which is their favoured model. And in Surrey, for instance, the first consultation with district councils wanting 3, the county wanting 2, and they've now come back and said they're going with 2. Not that that's any clue, but it's just so as you're aware it's underway. Thank you very much. We are coming now to the Better Care Fund first quarter report. Will Harbert, I think we can be quite brief on this, I think, Will.
We can be quite brief. So we're on track for residential care admissions and avoidable admissions based on the latest data. That is a shift on the residential care admission metric from the first quarter, so a positive movement there. We're marginally off track on the discharge delays, so we'd set a target of 0.48 for the average discharge delay, and it's 0.5 days. However, there are gaps in the national database on this, so the data's incomplete for MSEFT and PAH on that one. We've got a number of schemes that just want to highlight supporting that metric. So we have our home to assess approach, which is moving assessments to the community rather than the acute setting and supporting more timely care planning there. We've got the West Essex complex beds piece that has significantly reduced length of stay in West Essex, so a really positive programme there supporting that metric. And then also a number of voluntary and community sector schemes that are really helping us with those discharge delays, particularly around things like hospital transport. So we expect all those schemes to support progress on that metric into the next quarter. The other bit I just wanted to highlight is we are expecting guidance for next year. That should be coming out in the next month. However, I've heard it's been delayed to the start of December, and they usually delay it again. So we should see that around end of December time, I expect. They're talking about a tightening of criteria there and more of a focus around intermediate care, but also in the same breath saying there'll be an alignment to neighbourhoods as well. So we do need to see what comes out in that guidance and how those two kind of paths will match up. Other than that, it was just if anyone had any questions on the report.
Nothing else.
We are required to receive this report. Has anybody got any comments on it?
Peter
Things are broadly online. Peter Davey.
Thank you, Chair. Yeah, I'm surprised under 4.3 that the BCF metrics were changed. There are no longer metrics on falls or reablement. And as you know, I've raised before with you, Chair, there's around £250,000 reported inpatient falls in England and Wales annually. And these incidents result in approximately 100,000 injuries each year, including around 2,000 hip fractures and 600 other fractures. In-hospital falls are associated with significant cost, estimated at £630 million per year, and can lead to psychological problems, decreased confidence and longer hospital stays. So I have no understanding of the logic of removing it.
Well, no, the decision was made some time ago by government. I could guess, but whether any of the ICB chairs want to help me out, they aim to have the Better Care Fund focusing on those areas where there is greater dependence on cross-system working, but does anybody have better insights as to why the government changed the criteria? I mean, this goes back some months now. But we just received what the criteria are. Nick?
Well, the government is reviewing the Better Care Fund end to end. They are seeking to reduce the number of metrics and measures. They are also looking at the proportionality of NHS and local authority contributions. So this is just part of that process. I think you're identifying a really good point because there's some risk in that, and one of the risks is in constraining the metrics and the number of areas that they're looking at, our ability to use the funds locally for things that actually matter in our context becomes trickier. So it is something I think we need to be aware of, and probably it's to push back on to a degree, but I believe, well, it's been part of that process of tidying up.
And you would certainly, this has no constraints on what the ICB, what we all agree should be the key performance priorities in the ICB, Peter. Ian Davidson?
It's a more general point, actually. These figures hide the vast amount of work that goes into this being achieved. These are very, very big budgets, very, very complex contracts, very, very complex piece of work. And I just sort of think we should pay tribute that, a little bit of nothing to see here, but it's nothing to see here because there's so much work that goes into it and so much good stuff goes in. So I just kind of want to highlight on that. And just one which is kind of affects the county in different ways in different areas, but the residential care, that's to have actually got to the figures which are in there and expected for Q3. That's no mean feat. So again, recognising that that's in there and what they've achieved.
No, thanks, Ian. I take that as a wee bit of coaching for the chair, which is absolutely fair. If members are content, we will minute our recognition of the huge amount of work that comes into producing performances like this. So thank you, Ian. Anybody else? So we note the Better Care Fund report. Sarah, you are hoping to get some strong guidance as you come to finalise the health and wellbeing strategy.
Yes. So just, I'm going to hand over in a minute to Shamit and Chris. The Health and Wellbeing Strategy is a joint document, it's a partnership document. It's a statutory requirement. If you remember, we talked about the need to try and amalgamate as much as we can together that we're already trying to deliver, that will help deliver on health and wellbeing for us in Essex. We have done a first draft. That is based on the feedback we've had so far, and we are in the process of doing consultations with key partners. Some of you will have had those conversations already. So really interested to hear your feedback so that we can feed that into the next draft and get this right for us so we can then use it to inform our work going forward. And I'll hand over to Shami.
Yeah, great. Thank you, Sarah and Chair. I mean, just a few words from me because I was sort of co-author of the paper. I mean, the current strategy was agreed 3 years ago, and I think we've seen some improvements in relation to what we agreed back then, and Chris will mention some of this in his presentation. As we've heard this morning, we're now in a period of major reform with significant changes across the NHS and local government and a clear policy shift, particularly around the 10-year NHS plan. So I think the strategy we've drafted, and it is a very first draft, is to keep pace with that change and prepare for the future. And as Sarah, you've alluded to, we want to hear your feedback, comments, observations, particularly around the sort of shared vision priorities that we've set out in the draft. And we've tried to premise it around reducing inequalities across our population. So hopefully you've had a chance to have a look at that. So today your feedback is quite key. So Chris, do you want to sort of take us through the main points? Or
Yeah, sure. So can we go to the next slide, please?
Just as you come in, Chris, and just the reminder, please, this is not an Essex County Council Health and Wellbeing strategy. It is the strategy of this Health and Wellbeing Board. Chris?
Yeah, sorry. So just to build on what Shami said, the purpose of today is to just to basically give you a sort of whistle-stop tour of the strategy, so we can get a bit of a steer on the vision, the priority areas, and the guiding principles that underpin it, and also around the public consultation, which is also a statutory requirement of the strategy. Next slide, please. I mean, we've talked a lot about this already. So obviously the NHS 10-year plan, the NHS system reforms. But in addition to that, in May 2026, a new mayor will take office with duties under the English Devolution and Community Empowerment Bill. And these include improving health outcomes, reducing inequalities and promoting cross-sector collaboration. In addition, in 2028, 15 councils are going to be reduced into fewer, larger unitary authorities. So each new authority will require its own health and wellbeing board and strategy. So we need a strategy to help us over the next 3 years to navigate through a significant period of reform. Next slide, please. So the challenges, I mean, obviously, we know a lot about the challenges, but when we talk about health outcomes, it's not just hospitals, GPs and clinical care, it's more the things that shape our health, which occur outside the health system, so the wider determinants of health, so things like housing, education, employment, transport, and digital access. And these factors don't just influence our life expectancy, but our healthy life expectancy, which varies by 10 years, depending if you live in the least or most affluent parts of Essex. And there's loads of challenges, but I'm just going to name a few. And so I mentioned earlier the ageing population. So 1 in 5 people are now aged over 65. The number of people aged 70 to 74 has grown by 44% in the last decade. Child poverty is rising. So with over 55,000 children living in low-income families. There's been a 31% rise in households living in temporary accommodation since 2019, affecting more than 3,000 children. Nearly 1 in 5, this one did shock me a little bit, nearly 1 in 5 working age residents is economically active. And if you live in rural parts of the county, it can take up to 90 minutes to reach a hospital by public transport compared to the national average of 60 minutes. And tendering has a higher rate of digital exclusion. So they're just very high level things. There's loads of challenges. But improving health means tackling these wider determinants, and this ethos underpins the concepts mentioned in the strategy. Next slide, please. So what have we learned from the current strategy? So there's been a lot of collective work that this board has overseen. So things like the coordinated detox service, the Topaz ward at Brentford Hospital, Essex Pedal Power, the Activate scheme, fire safety visits, free lung health checks. So during the life of the strategy, the health index in some of the most deprived areas of Essex has improved by 4.7% compared to just 0.8% nationally. And some of the key health outcomes that have had a positive movement in that period, the suicide rate in Essex is now consistently below the national average. Drug-related mortality in Essex is half the national rate and is a reducing trend across the districts. Alcohol-specific hospital admissions are low and declining. Alcohol-specific mortality in Essex is significantly lower than the national rate. Obesity at reception age in Year 6 continues to be lower than the national average, and Essex performs well in relation to older adults regaining independence after reablement. However, there are areas that we can strengthen through the new strategy, such as whole system ownership, ensuring that all organisations understand the role we play, and we also need a clear visibility of how actions translate into outcomes, and we need a stronger approach to monitoring our progress, and we need a stronger focus on the wider determinants of health. So looking forward, there are some significant opportunities. So we can reset the system, align with national reforms and harness population health data and digital tools to target intervention more precisely and effectively. However, these opportunities come with some risks, such as obviously uncertainty of the future, plus persistent workforce capacity challenges, plus obviously the next 3 years through our transition period, with all this reform going on, this could be exacerbated by the system reforms. Next slide, please. So the purpose of the strategy is to meet our statutory duty. First and foremost, we have a duty under the Health and Social Care Act. We need to stay relevant. A lot has changed and continues to change since the current strategy. So this one needs to reflect the current changes. It provides a transition framework to ensure continuity during major reforms. It aligns with national priorities, supporting the NHS 10-year plan by focusing on prevention, community-based care and tackling wider determinants of health. And it also looks to address health inequalities by targeting neighbourhoods with the poorest outcomes. Next slide, please. So with all that said, our vision, this is just a draft vision, but this is the vision that we've put forward, that all residents are enabled to achieve good health in safe and thriving communities with access to support when they need it. Next slide, please. So from partner workshops, surveys and data analysis, we've identified 4 areas of focus. And this is set out in the paper alongside with emerging priority areas in a table which hopefully you've had a chance to review. So number 1 being improving life chances for children and young people, which is about supporting mental health, reducing poverty and safeguarding children. Number 2, helping more people into work and stay in work, so creating inclusive employment opportunities and building a future-ready workforce. And number 3, building healthy, resilient, connected communities is about creating healthy places, fostering social cohesion and improving access to services. And number 4, which is creating opportunities to improve health and reduce poor health, which is about promoting healthy lifestyles, reducing harm from tobacco and alcohol, and supporting mental well-being. Next slide, please. So in the strategy and in the cover of paper, we set out some of the sort of guiding principles of the strategy, which are we will act early to prevent ill health and embed healthy habits across the life course. We will scale up what works, which I think has been mentioned already to a certain extent. Proven interventions, building what already works. Let's not reinvent the wheel. Collaborate, so bringing together health, care, local government and community partners to align efforts and maximise impact. Rooted in place, so adopt a place-based approach supporting neighbourhood health plans and boards to reflect each community's priorities. Advance equity and inclusion, so ensuring services reach those most at risk and responsive to diverse needs. And use data and insights, so to track progress, measure impact and hold ourselves accountable through strong monitoring and continuous learning. So they're the kind of the main parts of the strategy. I guess the next step of this, next slide please, is how we is the public consultation. So we have a legal duty to consult the public, and our approach builds on the model that we used last time. But what we're proposing to do is launch an online survey, so this will provide a clear opportunity for residents, partners and stakeholders to share their views. Ensure accessibility through alternative formats, so this will be available on request, or we may provide hard copies in libraries. Engage with our stakeholders, so here we intend to organise and deliver briefing sessions and the detail of the strategy with our partnerships, and develop communications plans. This is currently in development about how we're going to, the different multiple channels we use to reach diverse audiences to promote the consultation. Next slide, please. So the ask of the board, and this is in the paper, is around the three options for the consultation. So there's option one, which is if the board is broadly satisfied with the spirit in which this draft version has been produced, we can commence a full 8-week public consultation on the draft in early December. So this would allow the consultation to close by the 2nd of February. It would just give us a good amount of time before the Health and Wellbeing Board in March, so that we can go to this meeting with a finalised strategy which is informed by the engagement. Option two, so we could start in the new year. So we could, if the board gives us the steer that actually we need to do a bit more work on this, we could consult in the new year. This gives us a little bit more difficulty around timing, but it still isn't. It's not a big problem. But if the board is broadly satisfied, so even if we did a 6-week consultation in the new year, which is the recommended minimum, it would conclude towards the back end of February. And it's that time between the end of the consultation and the Health and Wellbeing Board March that gives us a slight timing issue. So number three, we could do a shorter one for 4 weeks, which is what we did last time. And this, which isn't recommended by the government guidance, but it is what we did last time. And yet, with good justification, we can do a shorter consultation. Next slide, please. And so this is the timeline slide. So this just shows what the timeline would look like.
That's for information, Chris, just.
Yeah, sorry, John. Yeah. So this is the timeline slide that just shows what would happen if we did a December consultation. And the next slide is the asks of the board, which is just reiterating what we said at the start. That we're after feedback on the proposed vision, the priority areas, the guiding principles, which are in the cover paper, and provide initial feedback on whether it needs strengthening, are there any gaps, and agree the preferred approach to the public consultation, including associated timings.
So we're being asked if we're broadly satisfied so the guys can go to consultation straight away. Sarah, Chris, what's the hardest bit? It's easy to write the paper. What's the toughest bit of this? What do you think will go down least well?
Well, I think the toughest, I don't think there'll be any issues in the consultation. I think it's broadly acceptable. It doesn't go into a lot of detail, but I think the issue for us is to making sure we deliver against it and that it fits with all the different things that we're trying to deliver. So that's the challenge for us.
Less the consultation, more the plan.
Absolutely, yeah.
And did we see the plan in March?
We will see the final strategy in March, yes.
So when do we see the plan?
Once the final strategy is agreed, then we'll do some work with key partners to develop strategy. Maybe 12 weeks afterwards maximum, we should be fine.
Oh, we'll talk about that after.
Better to under-promise and over-deliver, John.
Right. Yes, Will.
Ian Davidson and then
right, I'll go to Gareth first, as you've not had a chance to speak, then Ian Davidson. Gareth?
Thank you. So I should have declared in my introduction, so my day job is as a Professor of Public Health, so my comments are in that vein. I think it's a great document. I think it's got real ambition. But I guess my question to us collectively would be is, I want to fly the flag for older people, healthy ageing. And I do wonder, when you say the document's about all residents, if I look at the priority areas, could it be more explicit about healthy ageing? Could it be more explicit about healthy life expectancy? Because the danger is we slip into focusing on life expectancy without focusing on healthy adjusted life years. And I'm sure that's not the intention. But I think if you're explicit about that, it would give confidence to older people like my mum.
I'll collect 2 or 3 points and then come back. Ian?
Thank you, John. I think it's a really good document. I think you really sort of capture the essence. And I'd link it to an item we had earlier. I'd link it to James's item because actually it's quite complementary in the way of working. So actually that's really helpful both for James's working in the neighbourhoods and the health and wellbeing strategy and vice versa. So I think that's really good. I don't know if actually perhaps we could even reference it because I think that might be a useful kind of link out because otherwise we end up doing things in isolation. On that work, I would recommend if in terms of from my point of view, we'd go with option 1. We go for the 8 weeks. The reason for that, apart from anything else, is that if you're going to give local health and wellbeing boards time enough for it to get onto their agendas, having 4 weeks probably wouldn't be enough. Whereas actually, if you have an 8 week agenda, you can usually get it in a cycle onto an agenda, because they don't meet every 4 weeks, they might meet every 2 or 3 months, so it's much more likely to get on.
Good point.
And the last point will be around the older people. I mean, tendering in Parochial has a lot of older people, and that's the highest rate of our pod, but I think that we must make sure that actually all of our population feel included, though, because obviously we're not excluding children, which has a significant issue for Essex, and also what we would call some of our isolated communities, such as rural communities, and how they access health. So I think that your point is right in terms of numbers, but I do think that it needs to feel as though it is including all.
Thanks, Ian, and some very good practical advice. Ian Tompkins.
Yeah, just really reiterating what Ian said, and also back to Nick and James's comments earlier, because, the buy-in with other initiatives and programme boards is essential, not just in terms of local health and wellbeing boards, but certainly in Harlow. I was at a meeting of our Community Safety Partnership last week with Pippa and FCC. And there was little interaction to date with the Health and Wellbeing Board there. We're going to get together. And also an important network to plug this into, of course, is education. Much of it is about children and young people. It's absolutely paramount that we do involve them. So from a personal point of view, 8 weeks.
Thank you. Anybody else?
Can I just
Will, and then I'm just want to know from you what visibility our colleagues in Southend and Thurrock have had, but Will?
Yeah, just very quick comment, and thanks for the presentation. Chris, I hate to take issue with you on something, and it's purely a presentational thing, but when you did the list of why we're doing this, first and foremost because it's a statutory obligation. For me, and I may be in danger of becoming an idealist over this, is that that's incidental. I think the reason we're all gathered here and the reason we want to do this is to make a difference to people in Essex. Oh, and incidentally, it's a statutory obligation. So for me, it's the other way.
In my introduction, Will, I just didn't say it.
That's a wonderful compliment to me. He's like,
Thank you.
Sarah, Southend and Thurrock have had visibility?
Yes, Southend and Thurrock know that we're doing this. They know what we're doing with the priorities. We've shared it with them. Thurrock are going to align their strategy with ours in terms of timescales and look for similarities where they're happy to do so. Southend are not doing a refreshed joint health and wellbeing strategy. They're just focusing on a couple of issues from their current one, but there's nothing in there that's any different. So, yeah, there are very strong similarities.
The only contributions I've had so far are people who are comfortable that we proceed now to an 8-week consultation with that very practical advice from Ian Davidson. Is that the wish of the board?
Yes. Yes. Yes, there's nodding heads.
I had about 5. Oh, nods are so useful to a blind man. Honestly, is anybody deeply uncomfortable? No? No. Then we proceed on that basis. Thank you, Shami. Thank you, Chris. I really will. Anyone can write a paper, Sarah, what happens, whether it matters. So.
Absolutely.
Good. And can you make sure that it's in the forward plan?
If I may, if Shami would like support at local government from the district perspective, we're happy to support that as well. So I know that the team do a brilliant job and know all inside out, but if it just gives a district perspective, that would be good.
Could you just link in, help us with what's the best way to make sure that every district health and wellbeing board's aware of it, okay? Yeah. Whether it's through you or whether we send somebody or whether we do both, okay?
Yeah.
Thanks, yeah. Right, now we're running a bit behind, but we've had good quality discussion. We're coming on to dentistry, and I'm not quite sure who's doing this presentation. I think somebody's remote, are they?
We've got Catherine and Emily here from Public Health, and the ICB are joining us online. Sorry, I've not got names. Stephen Claydon, Peter Whiteman, and Christian Fogarty.
I assume everybody who's involved knows the choreography of this.
Yes. We're handing over to Emily.
Excuse me. This is a follow-up, if you remember, from a session we had on dentistry a year ago,
Yes.
when there was quite a lot of concern about dentistry deserts and so on, and we got a good lot of reassurance. So we're going to get an update. Much concern then, of course, about young children. I will just say at a meeting earlier this week, we did hear from at least one county councillor a claim that pensioners are finding it very hard in Colchester to get dentistry appointments, but we've had no follow-up, have we?
No.
So over to whoever is, who's orchestrating?
Emily and Catherine in the room.
Catherine?
Yeah, we'll first start with the ICBs do their introductions and then we can follow on.
We can just make sure you leave time for discussion, okay?
Yeah, so if I hand over to Peter.
Yeah. Hi, everybody. Can just check. You can hear me okay?
Yeah.
Okay, thanks. Hi everyone, my name is Peter Whiteman. I'm one of the directors at Suffolk and North East Essex, and we've met as a group of ICBs just to put our presentation to you together. Thanks for inviting us to present this position on oral health, and as you've rightly set out, this has been a massive challenge for us in Essex and across UK really, trying to recover the access to dental services and quality of oral health. This is going to be the last report that we'll do with 3 ICBs, as you know, so it'll be obviously a single report going forward. There's quite a lot of similarity in how we've approached it as 3 ICBs, but there's obviously a bit of nuance, and we're just going to give you a couple of headlines with each of us just speaking shortly, but allowing plenty of time for discussion, and there's lots of information in your pack to refer to. And just to emphasise, we are working, as well as delivering our agenda for the next 6 months, really closely to get a smooth handover, so all the projects that we've got live across the 3 ICBs continue in their transition success into Essex ICB in April. So one thing I just wanted to flag up, as you probably know, for all ICBs, there's a national target that the new administration government has brought in with regards to access to urgent care. That's partly covered in the papers, but since we wrote the papers, that's been further strengthened. And each of the 3 ICBs now has a service that if you have an urgent problem with regards to oral health, you can come through NHS 111 and are connected to a practice that's got protected capacity to ensure that people who have that need can have their need met. So often it's been characterised in the past about people pulling their own teeth out, etc., and horrific stories such as that. That's exactly what this change is aimed at. So there should be no circumstance in which people feel they're in such a desperate situation as need to do that, because of all of these services that we put in place, and particular new different agreements with our practices across Essex to ensure that priority access is there for patients. So, and we've been strengthening that further over the last sort of 6 to 12 months. So I'll now move into, that's just a headline comment, I'll now move into some very parochial comments from the North East Essex point of view. So we're each going to flag one particular issue that's live for us at the moment. Across Suffolk and North East Essex, we're implementing a number of procurements to bring in extra dental capacity to particular neighbourhoods where there's a lack of NHS resources. And in North East Essex, the health needs assessment shows that is the tendering area, and particularly so when we've allowed for the additional need that there is in the tendering area. And so we're in the process of beginning a procurement to secure 40,000 units of dental activity, which is equivalent to around 8 dental chairs. And I think a colleague of mine, Ian, went along to the tendering council to talk you guys through the work we're doing, and we're collaborating closely on potential facilities that may come through that. So in the next 6 months, we're hoping to have further new dental contract capacity on the coastal areas of tendering to add to the capacity that we already have. So I will pause there and hand over to my next colleague, which I think is in Mid-Essex. Thank you.
Good morning. My name's Christian Vocati. I'm primary care dental contract support manager on the very small dental team. So it's nice to meet you all and be here to share the work that we've been doing with you. An issue that I wanted to highlight from the report is our children and young people pilot, which I think would be of great interest. So we started the pilot in November 2024, so it's been running for a year now, it was a staggered start. One provider started in the end of October, and then gradually more providers have come on board. All primary schools in Mid and South Essex have been aligned, and the vast majority have been extremely enthusiastic. And we do work in consort with keeping in touch with various supervised brushing schemes across the patch to make sure that we go in either to support them, or we don't go in at the same time. But the offer that we provide is slightly different to supervised brushing, because in order, as well as going into schools and delivering supervised brushing, we're also carrying out a lift the lip soft assessment on children to see the level of need that is there. Which we've gone into. They've run 335 class sessions over the last year, so that's very very good. So we've aligned dental practices to a number of schools across the patch. They're running education sessions in practice, and most schools have positively engaged with this programme. Occasionally, we do come up against some schools that are pushing back, possibly due to time constraints, but also sometimes because of not understanding what we were requiring to do and the support that we were trying to give. Because aligned with the education sessions, we also, where children have been found to have dental treatment, they receive a letter that says your child would benefit from seeing a dentist. If they don't have a regular dentist, that practice is also as part of their contract, opening their doors to that child and their siblings and family to help to break down any barriers to access to dental that they may have. So it does come with a considerable addition that we would hope that schools would take on board. So we have had a few schools, 34 that are on our list where we've had pushback. But we've only had one school that has flatly refused to take part, which is disappointing. But this is where working collaboratively with yourselves and other groups, where it can put some soft pressure on to raise the profile of this pilot, but also reassure them that it's legitimate and it's not some a scheme to try and make money. Because I know that some schools, all kinds of different sources, where they might worry about the legitimacy of its source. So it can support it, raise the profile and emphasize the legitimacy of it. And that's really the ask that we just say help to support rolling out and encourage schools to take part in it. We've also met with 3 MPs so far, a number of MPs, to again raise the profile with those, so that they can raise any, if they get people coming to them in surgery saying that their children have struggling to get access, they're aware of this school programme, but also to put pressure on schools in their area to take part. So I think I'll pause there for any comments and questions.
Perhaps go on to West Essex, if that's okay, and then we'll complete as a trio, and then back to the room. Yeah, thanks.
Thank you.
Morning, everyone. Can you all hear me okay?
Yes.
Good. My name's Amy Curtis. I'm the Dental Transformation and Commissioning Manager for Hertfordshire and West Essex. 2 things that we wanted to bring to your attention are that we are just concluding our direct award process C for orthodontic contracts across Hertfordshire and West Essex, and we hope to go out to award in December, and this will provide a 10-year contract to current providers so that we have continuity of care for orthodontic treatment. And the second thing is the child-focused dental practice scheme. We have just offered a place which has been accepted to a practice in Harlow to take part in that. So there will be a month's worth of online training and in-person training for the clinicians at the practice taking part. And then from January, we're expecting them to start accepting patients working with community dental services. And that's for children and young people who are not who are referred into community dental services that probably shouldn't be receiving treatment there and should be receiving treatment locally within a dental practice. And yeah, so from January, we hope to start seeing patients go through that service.
Thank you, colleagues. And ICB colleagues, and from an Essex, what I will also add, from an Essex Public Health, Essex County Council Public Health perspective, you've all had sort of the report, so I'll just highlight the few very key bits. So the data shows that Harlow has the highest proportion of tooth decay, affecting nearly a quarter of 5-year-olds, and in Castle Point, almost half of the sampled 5-year-olds show visible plaque, which mainly indicates that they're just not brushing as well. We know from evidence that supervised toothbrushing is an effective intervention at reducing tooth decay. Across Essex, already over 3,000 children are benefiting from targeted schemes, which we've picked through ICB and using dental data to target priority areas. In this case, this includes Colchester, Tendering, Basildon, Harlow and Castle Point. And we've seen really good result, really good feedback. And thanks to national funding, we are planning to expand this offer of supervised toothbrushing over the next 2 years, reaching an additional 3,000 children beyond the originally identified areas. And from myself, the ask from the board, the Essex County Council Public Health team are in the process of creating an oral health action plan, and we will be reaching out to partners to support the plan as and when that is complete. Happy to take any questions for myself at ECC Public Health or ICB colleagues on the screen.
I mean, Catherine, from my perspective, so I'm hearing a lot, and thank you, Peter and Christian and West, whoever, what was his name? Oh, I forgot, sorry.
Amy.
Thank you. Sorry, I should have remembered your name. Sorry. I'm hearing a lot of what's been done. What has actually been achieved, Catherine, so far? And what is our goal? If we aligned this to the timescales of the health and wellbeing strategy, for instance, where are people trying to get to? At what point will people feel that is a satisfactory situation?
So I think, so there are two different elements to this paper. We've talked about the access piece, which is very much in the hands of ICB colleagues. So would Peter or colleagues like to sort of describe where we are in terms of aspiration and targets?
Sure. Shall I kick off, and then colleagues may want to come in? And we put a few of the headline numbers in the page. I think one of the best ways to measure our progress is the number of individual or percentage of adults able to access an NHS service, and you can see the growth that we've seen in Essex recently. I think it's around the 4% level, which is compared to about 2% nationally, and also the access rates per head are higher in Essex compared to some of the other areas. I think Essex is delivering better than it has in the past and better comparatively to other areas, but we absolutely recognise there's a lot more that we need to do with regards to access. So we're looking for year-on-year improvements in the percentage of adults and children and reduced variation in the percentage of adults and children across our areas with the ways to measure our success. So progress made, but more to do.
Thank you, Peter.
And just to add from those sort of the public health perspectives, we had 250 children in 2024 who had a tooth extraction under general anaesthetic, and that's an avoidable situation. So through the work that Emily's doing on sort of supervised toothbrushing programmes, which we know are effective, we're hoping in the longer term that helps to bring down some of that consequence that we're seeing that on and that pressure that's creating for NHS healthcare partners, essentially. But as Emily mentioned, we are working up an action plan and actually really keen to try and put an aspiration and outcomes around that action plan in terms of what we would like to achieve.
I think that's where my priority always feels, the notion of children aged 5 or at primary school having multiple extractions. And I take NHS colleagues, the pressure it creates. Much more important is what it says about the child going forward. You know, not having their own teeth at the age of 11. I just find, what does it say about the other health conditions at home? So, keeping a real force. I still remember from my days in Edinburgh, Scotland, you see, at the age of 6, 7, the Happy Smile campaign, And the stamps we used to get at school when we'd put in the stamp on the book that we cleaned our teeth twice a day, it becomes a lifelong habit.
Absolutely, yeah, absolutely. Want to instill those that habit from a very young age.
And Scotland is a very good case study as to what they're doing. Currently, they have an entire oral health programme, which has multiple aspects, as supervised toothbrushing in schools, as a fluoride varnish programme, has all this really key, very good practice that, of course, we are looking towards, and they've done a great job up there.
If Helen was still here, I'd be asking her about how we tie schools in better. Chris Martin, you're still here?
Yes, I'm here. Sorry, I missed that.
It seems that schools are a key partner here in the way that Emily worked with Nourishing Our Future, with the early year settings on food. Teeth cleaning could be another piece for that programme.
So I would agree, and I'm encouraged by the partnership that seems to be developed with schools. There's an additional aspect, and I think my colleagues from HCRG to my left are going to come in here. There's that element around oral health and a preparedness for school as well. So whilst I welcome the partnership that's been established in schools, there's a real opportunity, as I think I mentioned at the last session a year ago, working with our family hubs, who will be working with those families probably in greatest need in each locality, to develop and take up the opportunity to work in partnership with the hubs around an oral health programme preschool, so that those programmes that are assigned to school can be even more successful.
Okay, any other questions? People? Yes, Will?
Sorry, John. We do have hands up from Ian and, sorry, is it?
Rosie.
It's Rosie from the HCRG.
I'll take you, Rosie, first, and then Ian.
So first and foremost, I really welcome everything that we've heard today. This is really promising information, and I think within HCRG and within health visiting and school nursing, we're very much involved in a lot of these initiatives. Christian, if you want to reach out to me at any point, we will probably be able to help you in accessing some of those schools in Mid and South Essex through our school age workforce that might be of assistance to you. We're also working very closely with Catherine, etc., on looking at how we can also influence at a very early age. And again, we welcome very much being part of that action plan as you develop it going forward. We already have a strong focus on oral health and the importance of that, be that through making sure that every family, when we undertake our developmental reviews, are already at least familiar with their dentist, attending a dentist, and have an understanding before teeth even come through of the importance of brushing. So there is more and more work that we can do in that early intervention, and again we very much welcome that and being part of that going forward. So please do make sure that we and the hubs are massively involved with this programme. Thank you.
Thank you, Rosie. And Ian, that feels like living integration to me. Ian?
It is indeed.
Just to say is that in tendering we have an education board which all the schools are on, and I don't know if that's consistent right across Essex, but certainly that would be a way of getting, because there are the board and local authorities can link in as well. So you can certainly go to the education board that's tendering to talk to them about principal events, and that may be an avenue in for other areas as well.
Okay, thank you. I think there is an action, Catherine. Perhaps you could, in due course, come back and tell us how we're going to fully engage schools. Ian Tompkins?
Yeah, I'm just going to beg your attention, everybody, for about 15 seconds, just to premiere a video we did in Harlow with 90 pupils from Henry Moore School.
Ah, yes.
Here we go. Yes, we're also now going into production with a similar one, because it's all related. We Will Eat You, a take on the Queen song. That'll be premiered probably around February time. But if we could just play, yeah, thank you. You're all welcome to use that. I will be putting it on a YouTube channel, but yeah, please do share it and then watch this space for the eating one.
In a moment of clairvoyance, I was thinking overnight about the School of Manchester that did the song Grandad, which got a number one Christmas hit. Whether they're quite going to do it for the Edinburgh School, I'm not sure, but wonderful. Thank you. Thank you for bringing some joy into our lives here. And that feels suitable. But I think any other points people want to make on this has been a very useful presentation. Thanks, Catherine, and everybody else involved. Yes, Will? And Emily. But it was the lady from Norway. Amy, sorry, I do apologise. So thank you all very much. We're going to very clearly take forward this work. Chris, you're picking it up on the schools team. Now we're about to just have a 2-minute pause. Well, 5 minutes if you insist. We're going to start the next part of the meeting with an excerpt from quite a long video about childhood in Essex Forest. And this is listening to some of the childhood voices in Essex. But I talked earlier about it being a first meeting for Gersh and Mike coming back from the grave. I don't want to say the dead, Michael. It is a final meeting for one of our members, and I think Ian Davidson and I particularly recognise the extraordinary contribution that Jane Gardner has made to the health and well-being of people in Essex. Wherever I go across different boards, what Jane has done in the worlds of domestic abuse, in thinking about prevention, working through the Police, Fire and Crime Commissioner's office, and of course particularly in how we really develop effective oversight of suicide prevention and mean it and work.
We're just passing on the. That's why. Sorry, that's what I meant. Yeah,
Ladies and gentlemen, ladies and gentlemen, boys and girls. We get your police team in a minute. They're having a bit of trouble. It doesn't matter when we do the video because at the end.
Sorry, Jane.
Could we
knocked you out then.
Serena,
Yes.
can you come and talk, please? But about 15 minutes. Please make sure we leave plenty of time for discussion.
Jane.
I'll tell you when the. Katrina?
Shall we start?
Yes.
Okay, so while the ladies are preparing the video and also slides, I'm Katerina Glover. I'm a senior researcher in the Research and Citizen Insight team.
Yeah, and I'm with Katerina today, so I'm Emily Brody. I'm the intelligence in the Citizen Research and Citizen Insight team.
So we're from the team that delivered this Childhood in Essex research project, delivered on behalf of the Children's and Young People's Strategic Partnership. And the research, hopefully you've had a chance to look through what was provided in your agenda pack. Just to reiterate, the fundamental question was, what is it like to be a young person in Essex today? And we did that by looking at two specific aims. One of them was to examine how childhood has changed compared to the previous generation. And the second one was to explore and bring to life the everyday realities of children and people living in Essex today. And the remit of the work goes beyond any organisational boundary. It is relevant to any individual or organisation that works with children and young people. And it is intended to aid system partners in decision-making and informing the development of policies and strategies, and also interventions aimed at improving outcomes for children and young people. To reiterate who we engaged with, we established an exceptionally rich and robust evidence base from children and young people aged 9 years to 18, their parents, and also professionals. And we did this through a number of ways. We engaged with children and young people through 2 one-week online communities and also through group discussions at youth groups. So children, young people gave us the background, obviously, to their everyday realities. We also engaged with their parents, who gave us a bit more about the changes in childhood and another perspective on those everyday realities. And
Katerina, I'm just if I may, you don't need to read the slides, you know. What I really want to do is move through so as we get good discussion, because the findings are what's really fascinating.
So we also engaged with professionals. So we had a whole spectrum. And then we identified kind of 4 key changes in childhood. They all kind of influence each other. There are technological advancements and rise of social media, awareness of adult concerns and desensitization of young people, independence and safety, and finally mental health and emotional well-being. And that is the one that we will focus on today, because that's really more of the remit of your board. Do we have the slides with the actual text?
The video or the slides?
The video ready?
The slides.
The slides you'd like.
Do you want to show the video first? Is that what you want to do?
Up to you.
Let's decide.
I'll just
Perhaps to do the slides.
Do the slides, yeah.
And then do the video again.
So focusing on mental health and emotional well-being, which is the kind of 4th key change we identified, there's a general agreement that children and young people face a lot of different pressures and challenges these days, because the context in which they live now is dramatically different to what it would have been in your childhoods. So there's a lot of pressures around educational pressures. They want to do well at school, but at the same time they feel like they're being evaluated a lot. Then image and appearance matters a lot to young people these days. There's a lot of pressures from social media in terms of their how they kind of present themselves, what they look like, how they behave, what they own. So overall, there's these pressures mean that young people don't always cope well with them. So there is just general rise in mental health challenges. And alongside this, we also have a shift in terms of attitudes and also awareness and acceptance around mental health. So young people are happy to talk about it much more these days. They understand that it's kind of okay not to be okay, but this also brings challenges with it, because talking about mental health and all the information that they're being fed from all sorts of sources can result in mental health conditions and symptoms being miscommunicated, misinterpreted, and so the way they're discussed by young people might not always be in a healthy way. Secondly, professionals reflected that this mental health acceptance and sometimes can lead to missing the middle ground. So we need to focus more on teaching children, young people, on how to kind of cope with things, coping techniques, building their resilience, so that they know how to deal with sort of more challenging situations as well as the everyday on their own. And finally, although there is more mental health support available these days, it does not necessarily match the supply. The supply does not necessarily meet the demand. So some families can be experiencing long waiting times or support that they feel is not really meeting their needs. And also at schools, again, more support than there was before, but this can be provided. This might not always be completely consistent or not provided discreetly. Young people want to reach out, but in a discreet way. So essentially, we're facing an increased number of children and people with mental health challenges and complex needs. This creates a lot of stress, both for the whole family unit, and it means that there's more children at risk of these issues persisting into adulthood and having more lasting impact.
So throughout the research, we did ask participants for suggestions in terms of how their lives could be improved, both now and kind of in the future. And the suggestions that we got back from participants fell largely into 3 areas. More details of that are in the final report, but for today, we're going to really focus on one of the suggestion areas, which is around improving access to timely and preventative mental health support. So this doesn't mean that these things are not happening. These are just observations from our participants in that they might not be happening kind of enough or consistently. And as Katharina mentioned, while participants kind of acknowledged that the awareness around mental health is improving, the supply doesn't always match demand. And the delivery and practice isn't always aligned to the needs of children and young people. There is a need for it to be kind of easily accessible and discreet. And there was just a couple of suggestions that came through from this as well in terms of implementing things to support children and young people to learn tools and techniques to cope with everyday situations as well as more challenging situations and build that resilience, and to implement things like training for professionals that work with children and young people on a day-to-day basis, focusing on building in their understanding, recognition of mental health, and their ability to respond in that moment. What we found from the research that young people were more likely to trust those people that they worked with day to day, not necessarily the professionals that are in place for kind of mental health. But that's a really kind of brief overview of what we're going to discuss. So we've got a quick video, a 2-minute video to kind of show you now, and then we've got time for some discussion.
Thank you. Thanks.
Sorry, we'll just grab the video up now.
This is part of a much longer video. I think you've had the link given to it in your papers.
Yeah, the full video is a 10-minute one, so this is really just a taster.
Do you remember what it was like being a kid? Like, really being a kid? Before phones, before tracking apps, before the world felt so loud. Because for us, childhood's a bit different. We're growing up online and in real life at the same time. We know what's going on in the world, sometimes more than we want to. Yeah, we still laugh lots, hang out with our mates and watch dumb stuff on TikTok. But we're under pressure too. From school, from social media, from trying to figure out who we are in a world that is constantly watching. So today, we want to show you a bit of our world. There are over 300,000 of us growing up in Essex right now, and it's time we shared our side of the story.
We're growing up in a world where I can send a message to someone in 3 seconds, less than that, half a second. People don't understand that ease of access and that they think we're addicted to phones and that sort of thing. I think we need better access to lots of things, public places that we can go to and spend time.
People really find it hard being themselves. A lot of people are stuck in friend groups that they don't want to be in.
I personally am excited for, further education, going to career, university and all that.
Children these days are up against it. The spotlight is very much on them in so many different ways in comparison to our childhood.
If you're someone who makes decisions in schools, in councils, anywhere, don't just listen to us because you have to. Listen to us because we've got something worth saying. Because the world you're shaping is the world that we're going to grow up in. This is childhood in Essex, and we want to be ready for it, together.
The longer video is well worth a watch. The Children's Partnership Board, where many of the organisations in this room are represented, we spent probably, 45 minutes, an hour on this, Katharina? And then during November, on World Mental Health Day, I was in various parts of the county, listening to our young people and listening to those who work with our young people in the Children's Society, in the Wilderness Foundation. And this isn't telling you anything we don't know. It is the voice of the children and young people telling us that I think what I heard on that day was salutary and being even stronger feedback than I might have expected. The ever younger age of self-harm, the ever more violent behaviour that they are seeing from children whose mental health is in such a poor state. The purpose of this item is to inform, Katerina, those who will be thinking about the priorities in public health and medical strategies, I think, but Katerina, yeah?
Yeah, definitely.
So,
It can, the remit of the work goes well beyond Essex and relevant to pretty much anyone who works with children and families. And the report is definitely worth a read. We go into much more detail with some additional resources. So please look on Essex Open Data at our Childhood in Essex page, where everything is available, as well as the recordings of our event, where you can get much more detail too.
We have a few minutes for discussion.
Ian Thompson, Will Pope.
Will Pope, then Ian Tompkins.
Oh, you want me to go first, John? Thank you very much. This is great work and really important work as well. So great report, great videos. And essentially, this is the future, isn't it? So it's really important to get this right. And I've got a question to ask, and apologies in advance if I should know the answer to it. But John, do you remember over the past year, 18 months, we've been building on foster-friendly employer approach, which is really important as well. Do we have a system for supported lodgings for, say, 16 to 21-year-olds who for some reason have become separated from their family for whatever reason? Do we have an Essex-wide system for that?
I'm going to bring Chris Martin in. Firstly, Will, thank you for bringing up fostering friendly employers. I'd have to say, I would have wished for a more significant response than we've had so far. We had a meeting internally in the County Council only last week. It is December last year that every district council promised to become fostering friendly. So far, I think 5 have. And it isn't, you're not a fostering friendly employer just by having a slogan. You need to have the policies that go with it. But yes, now 16-18 is an area of particular concern with those organisations I met who noted that it is at 16 they're seeing youngsters really fall away from school, from the system, all-night gaming in their bedrooms. And one of the issues with supported lodging is there is no supervision. But yes, we do have a supported lodging provision. Chris Martin?
We do, yes, and it falls within the range of semi-independent accommodation options that we have for young people. Some of that stuff has been recently re-regulated, so there is a cohort of support that was previously applied that was support and is now classified as care. So it's been under close scrutiny relatively recently for us. But yes, it does kind of form part of a spectrum of that sort of semi-independent accommodation offer. Yeah.
Oh, that's really good to know, John. Thank you. And maybe again in the way that we promoted foster friendly, maybe we could do supported lodging friendly as well, if the demand is there, which I'm sure it probably is.
I think there's quite a lot, and one of the great advantages of unitary councils, of course, is they bring a lot of the things around housing and accommodation into the same place as health, which is an advantage. But thanks, and we will be coming back out with a new action plan around fostering and residential accommodation for our young people. Who was next? Ian Tompkins.
Yeah, thank you. I was with, this is all very topical and timely, and is a major concern in secondary schools, certainly in West Essex, but that's not atypical. I would imagine it's everywhere. It's what they call for in the schools, or really are urging for, is early intervention. On a number of fronts. I mean, in terms of one of them, Natalie Christie at Passmore's Academy, which some of you may remember from Educating Essex, I was talking to yesterday, and we're undertaking a programme there, multi-agency approach, to study life as a girl in the Passmore's community. So we're using the school, but it goes beyond the school, because what goes on outside the school gates can be very alarming. And Natalie was telling me yesterday, typically from their experience, typically 40 incidents of domestic abuse before a pupil raises it. And again, your point about trust is key, because they will talk to teachers or fellow students about that. There's a lot of work to be done around the violence against women and girls work there. Another head teacher, Helena Mills, another big hitter in education, was telling me that she doubts very much there isn't one girl in her school that has not been exposed to some pretty perverse online activity and so forth. And then finally, just to follow on from Will's point, I'm also a governor of Harlow College, and working with the principal, Karen Spencer there, we found, because he seemed not quite himself, one of the students was living in a tent. Yeah. You know, so there's an awful lot to be done here. But if any way we can join in and support it through our forthcoming project about Life as a Girl in Passmore, more than.
Thanks, and that's very valuable, the girl at Passmore speech. I always say, you know, when I was a lad, if you were bullied at school, you got on the bus and went home. If you're bullied at school now, it follows you to your bedroom, doesn't it? Ian Davidson.
Thank you, John. A couple of things is we are approximately accredited, and we've actually had take up from our staff actually as well, which has been really pleasing support and support on that one. I'm with another hat on. I'm a trustee of Teen Talk, and actually one of the key things is about those organisations who we absolutely rely on. So we talk as the public services as the sector, but we so rely on the charities and on organisations like that. But they are finding it ever more difficult to get funding. They're finding it ever more difficult to operate, and we're seeing them close. And not Teen Talk, but we're seeing others close. So it is not just about recognising this. Is how we then support those who support, because we can't do it all as public sector. We need to make sure that mechanism is there to support them. And some of the stories which I hear at some of our work there is absolutely heartbreaking.
Got Ian. That's a whole meeting in itself, what you've raised there. Thanks for what you're doing in fostering friendly. I'd remind us all of our reliance on the voluntary sector. We know that, but tomorrow is Unpaid Carers Day, world, national, and that particular reliance in there, and asking employers to think again about whether they are being a carer-friendly employer, if you like, and they are working with those who have caring responsibilities and understand the obligations on them. And I am very well aware, actually, of where we are with the voluntary organisations of Essex. I was at the Community Foundation AGM last week, where the main charities across Essex have agreed now they're going to create something with the Community Foundation to be a much stronger voice for the voluntary sector in Essex. I did ponder where that sat versus the CVS's, but they assured me that they're all in the tent as well. And of course, there's worry, Ian, not just about making the disruption of relationships, because quite a few of the bigger ones get money from the county, quite a few of the others, well, all of them, get money from district councils like Tendring and Colchester, and that whole upheaval is a source of money. So we do need to help them flourish. Chris Martin.
Thanks, John. So there's a number of big strategic initiatives and documents that I'm aware of in situ at this point in time, and it'd be great if the work that we've seen and the research that we've seen this morning connects with the health wellbeing strategy in terms of the NHS kind of commissioning intentions and also around the NHS neighbourhood model. So it would be great if we can see evidence of the research informing those big intrinsic strategic documents for us to kind of trace the dots and the connection, particularly with the documents. I also think there's a lot within the Caring Communities Commission and that report which connects to children and the research and could also connect to those strategic documents. At the other end of the spectrum, John, you mentioned the Children and Young People's Partnership Board, and we had ECVIS come along and share with us the great work that's going on through our third sector, voluntary sector partners at a very local level, right the way across the county. And in essence, I think what they were saying is we just need to do more of this. And we're all kind of fully aware of the kind of funding difficulties, but it was a very compelling argument around the fact that there's not a gap here necessarily, but we just need to do more of what's going on really well at a very local level. So I just kind of wanted to make that connection between, you know, James's presentation and the neighbourhood model that's been developed within the NHS, and to build on the things that already are working for young people and what young people tell us through the research are working. We don't necessarily need a whole swathe of new things. So we need to kind of build on the things that are already working and are present and are in situ.
Thank you very much. I'm going to have to move on in a second. I know you want to come back in. Anybody? Oh, Rosie.
Thank you, Rosie from HCRG again. Chris is in many ways did exactly what I was looking at. Is about those multiple strategies where we do need to be tying up and making those links and making sure that they all feed into this agenda within school, our school age workforces, and indeed within our health visiting workforce who work with parents. We are definitely seeing a massive increase in the areas that you're discussing. So parents in their own right are also having increased emotional well-being, mental health issues, which again in that feeds into their children. So it is an issue across all ages, and we need to be focusing at every single contact and every point to be able to make a difference. I think Chris's point is absolutely right. We really need to listen to what young people say. I think there is too much of us doing unto rather than doing supporting and listening to them to enable them to be able to access. But there's an awful lot already out there, but we do need to make it a lot more accessible for people to be able to access, and it needs to be good quality information, well presented and in a way that is meaningful to them. So it is less of the TikTok generation, I'm getting out of my league now, and less of that Instagram culture. We need to be able to give them reliable sources of information that's desirable to them.
Okay.
Thank you.
Very sound advice, thank you. And the whole piece about cohesive policies rather than multiplicities of initiatives, absolutely. Ian, can I ask you to be very brief, please?
Just the funding thing, which is really important, which is why I was agitated to come back, was that the National Lottery and the Children in Need have actually changed some of their funding ways, and therefore, often for metropolitan boroughs where there are multiple offers for those different support, it is there. In certain areas of Essex, so it's not just mine, there are actually fewer providers of that support. And therefore, if they're affected by the limited timing of support, then that means that what will happen is that actually they will end up closing. So it is a real issue, and a number of organisations have talked to me about this. Outside the meeting.
Thank you. Catherine and Emily, sorry, Catherine and Emily, thank you for stimulating such a good conversation. A final sentence from you?
I think just there's a huge amount more information that's available on Essex Open Data. Please do have a look at the full video and the full report. It's great to hear that actually it can help to inform so many of these strategies. So if anyone does want to kind of have a further conversation, then do let us know.
I would encourage you to link up with some of the people I've spoken today, particularly the life of a girl at Passmore sounds fascinating.
We absolutely will.
On the co-production piece, Rosie, you know, our unpaid carer strategy is so much more successful now that we co-produce it with the caring organisations rather than tell them what we think they should do. We are well behind, and I've got a hard stop at 12:30 due to other meetings. So we must move straight on to the Mid-Essex Recovery College, and the speaker on this is...
Yes. Yes.
And this says to enable us to have an overview of the activities of the Recovery College.
Yeah, hi everyone. So I'm Vignesh, I'm the operation lead for the Mid-Essex Recovery College, which is under Provided Community Interest Company. Just to give you a very brief overview, we started in 2023. This is funded by the ICB It was a blank piece of paper where we had the opportunity to start the Recovery College from scratch. So initially what we did was we started off with doing a number of co-production work and trying to understand what's needed within the community. So currently what we do is we provide free mental health courses for anyone who lives or works in the Mid-Essex area. And usually the recovery colleges in the UK have a hub-spoke model whereby there is one building where everybody goes in to attend the college. But due to the community needs and various other points that have been mentioned in other presentations, such as the travel times and the inequalities, etc., what we've done is we have started delivering courses in multiple venues. So that's village halls, church halls, art galleries, etc., predominantly focusing on areas like the Dengie, Malden, Halstead, Southwood and Ferrers, and we're now due to start delivering in Wickford and Billericay. So some of the key highlights that we've achieved over the last 2 years has been things like we've had over 400 students attend our courses. We currently run from over 35 venues. We have got our 40 courses that we run, which includes things like anger management, bereavement and support, care for carers, which also includes a specific project which was ECC funded for unpaid carers, understanding unpaid carers. We also run various other courses such as anxiety management, etc. So the main reason for today's ask for myself is the fact that since April 2025, we have now entered a new partnership. So that's a Mid and South Essex Recovery College partnership, whereby we have we basically still cover the Mid-Essex area, but then we have partnered with two other organizations. So MPFT, which is the Midlands Partnership Foundation Trust, who covers the Thurrock area, and we've got Trust Links, who covers South End. The three organizations deliver courses across the Mid and South Essex. We have now started delivering in Billericay and Wickford, but we wanted to raise awareness about the courses that we're running and the services that we are providing so that we can encourage more individuals to attend the college. We currently get referrals and enrollments from social prescribers, PCNs, GPs, etc. But we've seen a decline from the areas such as Wickford, Billericay, Southwood and Ferrers and Halstead, where there is more need stuff. So it's more for collaborative working and to raise that awareness. Also, one key thing that we are super proud of is the fact that our team consists of around 18 staff members, of which nearly over 50% of our staff are ex-students, so individuals who came to the college, attended the college, and then did train the trainer program and became fully paid staff members. So yeah, that was the main.
Yeah.
No, thanks. How do you make sure that this just isn't a duplication of other initiatives? Taking back Rosie's point earlier, how do you ensure that this is doing something quite distinctive and is totally joined up?
Yeah, so one of the things that we have focused on right from the start was the framework ABCD, so asset-based community development. So one of the primary aims was not to duplicate what ACL is already doing or any other organizations who is already running courses, and instead using it as an opportunity to work together, because we all know that in terms of course providers and stuff, we're all working towards the same goals, which is helping individuals improve their mental health. So we have collaborated with a number of organizations, such as including APUT, where they deliver courses such as finding and retaining employment through the IPS teams. So we have collaborated with them to provide a platform to deliver the courses with us. And again, working in collaboration in that sense, rather than reintroducing something. If there is a particular area where there is anxiety management courses being run, we choose to signpost people to that area and we focus on other areas.
Okay, right. Thank you. Questions, comments?
Moira.
Moira?
Moira McGrath, Director of Strategic Commissioning and Integration for the Council. Recovery College is a really important part of the overall community model for mental health. It's something that we're looking at kind of reviewing and refreshing our model around community mental health across Essex. And Recovery College are a well-evidenced way of supporting people and very well embedded, I think, within MSE. We're also looking at, with ICB partners, at how that could be extended across North East and West. We'd like to see kind of universal coverage. That's part of the ICB commissioning intentions, I know.
So who commissions the Recovery College? Is it local government or the health?
It's commissioned by the NHS currently, but we work in partnership with the NHS on it.
Okay. Okay, so I assume I would look at NHS colleagues that you would be looking to see the impact of this with a view to then, if it's working, take it out across the county. Michael, Jay?
Yeah, no, indeed, as Moira has just sort of said, that is work in progress, yes.
If there are no other hands raised, thank you. It's not something I knew too much about, so it's very informative. Thank you. Thank you. You'll be next, Will.
Then we're on to the forward plan.
So the forward plan is underpopulated for January and March. So it is your board, and we've had 3 items today which came from the membership, not from the county council. So that's great. So please have a look at it for January and March. I will ask that we reach out to the Better Care Community, the Caring Communities Commission to see if and when they want to come back. And clearly Sarah signalled that there'll be the health and wellbeing strategy in March. So
John,
yes, Will.
Nathan's going to come in.
Sorry?
Nathan's going to come in.
Nathan?
Just to advise, obviously we have Christmas and New Year coming up, so that puts a bit of extra tightness on timescales. We would ask if we could get suggestions for items by the 5th of December. That way we can put it to the agenda setting group promptly and get requests and confirmation of deadlines out to report offers this side of Christmas without creating undue problems for staff. So 5th of December for suggestions through to the Health and Wellbeing Board email address, please, if possible.
Thank you, Nathan. Any other businesses?
Yep.
I've not been notified of any other business. Have you any, Nathan?
No.
Sarah?
No.
Anybody else? I wish you all a good journey home.
Just for the printed process, John, the item into the next meeting.
28th of January. I am very mindful of your time. And if we do not end up, this isn't, I could be giving you a false incentive here. I hope we get some good meaningful items. If not, we might just let the meeting go. Yes.
And then there's just if there's any urgent business or any exempt urgent business.
Which there was not. I would have been notified. Right. Thank you all very much.